Okay. All right. Good morning. Good morning. Yeah. Happy Sunday to you too, Hina. Yes. Good morning. Good morning, everybody. Wonderful to finally see the chat. I could not see the chat. So, okay. Audio, video, everything is fine. You're able to blurred image? Blurred image? Yeah. Okay. Nishit. Good morning. All right. Good morning. All right. So we can start, I think. Okay. Okay. No. Today is not the last day. Even your fourth day also, I'll be taking. The Dr. Jindal, the other physiology teacher, is not taking on the fourth day. I'll be taking also on the fourth day. So no worries. Okay? Yeah, I miss you too, Deepu, and good morning. So let's continue. So the plan for today is we will complete our CNS first. We have 1 hour of CNS left, which I will complete it with you, and then we'll take on the other systems, right? So all right, so let's do our CNS. Okay, so we had finished with the motor system, we had finished with the tracts, we had finished with cerebellum, basal ganglia, and we had also done the reflexes, postural reflexes, right? So let's go on to the, okay, so let's go on to the next part in CNS, and that is hypothalamus. So let's discuss the hypothalamus. Hypothalamus. Yes, let's complete our CNS first, right? Hypothalamus. Now, what is as far as the hypothalamus is concerned, bus, now let's stop typing. I'll be taking your complete physio. The son, I will be taking your complete physio, even on the fourth day. All right. Muscle, sab karenge. Bharat Kumar Soni, muscle bhi karenge. Don't worry about it. Everything will be done. All right. So let's start. And all right. Okay. So let's see the hypothalamus now. As far as the hypothalamus is concerned, what is the hypothalamus? Hypothalamus is called your vegetative brain. This is called your vegetative brain. Right? Hypothalamus is called your vegetative brain. Why is it called the vegetative brain? Why is it called the vegetative brain? That is vegetative because it looks after the vegetative functions. When I say vegetative functions means what? See, the cortex is your thinking brain, right? Especially the frontal lobes, these are your thinking brain, whereas this is the vegetative brain. It looks after the vegetative functions. When I say vegetative functions, it means it controls the cardiovascular system, the respiratory system, the GI tract. So those are your vegetative functions. So hypothalamus is your vegetative brain. It controls the autonomic nervous system, right? It controls the autonomic nervous system. Now, to remember which are the nuclei of the hypothalamus which are involved, there is a little mnemonic here, and that is hypothalamus has 10 hearts, right? 10 hearts. Hypothalamus has got 10 hearts. So what are the functions of the hypothalamus? Let's try and see that. When I say T is number 1 is temperature regulation. Temperature regulation, right? Temperature regulation. Now, temperature regulation, we will be doing it in detail a little just after this, after I tell you which are the nuclei for different. Then E is the endocrine function. Endocrine function, right? N stands for neuroendocrine. I'll just be elaborating on this. These are the functions of the hypothalamus. T is temperature regulation, E is endocrine, N is neuroendocrine, right? Then H stands for hypothalamus also controls hunger. So this is your hunger center. Hunger center is located in the hypothalamus. Which is hunger center? Hunger center is the lateral hypothalamus. Lateral hypothalamus is the hunger center. A, autonomic nervous system. It controls the autonomic nervous system, and autonomic nervous system is controlled by the periventricular areas of the hypothalamus. Periventricular areas of hypothalamus. We are doing the hypothalamus. Yes, I'm discussing with you what are the functions of the hypothalamus. And one small mnemonic, this says hypothalamus has got 10 hearts. T for temperature regulation, E endocrine, N neuroendocrine function. H is hunger center. Which part of the hypothalamus is the hunger center? Lateral hypothalamus. A, autonomic nervous system. Hypothalamus controls the autonomic nervous system. Which part of the hypothalamus? The periventricular areas. R, rage center. Rage center. Hypothalamus has got the rage center. Which is the rage center? Rage center is the lateral hypothalamus. Lateral hypothalamus is the rage center. Rage and reward. Reward center is also in the hypothalamus. Rage and reward. Reward center is the ventromedial hypothalamus. Ventromedial hypothalamus is the reward center. Rage center, lateral hypothalamus. Reward center is the ventromedial hypothalamus. T, thirst center. So basically, hypothalamus is controlling hunger as well as thirst. And which part of the hypothalamus? That is going to be the lateral hypothalamus. If you see this, lateral hypothalamus has got overlapping functions. Lateral hypothalamus is the hunger center, rage center, thirst center. That means if I take an electrode and stimulate the lateral hypothalamus of an experimental animal, yes, if I stimulate if stimulation of lateral hypothalamus is done, lateral hypothalamus in an experimental animal is done. If stimulation of lateral hypothalamus of this using an electrode, you can stimulate the lateral hypothalamus. What is going to be the response? The animal will be hungry. He will be hungry. He will be thirsty. He will be violent. And he will be aggressive, isn't it? Why so? Because the lateral hypothalamus is the hunger center, thirst center, rage center. So it's going to be hungry, thirsty, violent, and aggressive. And this happens to us as well, isn't it? Yes. So Prabhat, there is actually a term called hangry, isn't it? It happens to us as well. Whenever we are very hungry, we are also irritable and angry. So there's actually a term which is called hangry, right? Hungry and angry. Why? What is the physiological basis? Physiological basis is the overlapping functions of the lateral hypothalamus. Lateral hypothalamus, right? So this is the Kabir Singh Center. Okay, Kabir Singh Center. This is your lateral hypothalamus. Okay. Then with S is satiety center. Satiety is also a function. Hunger and satiety. These are both functions of the hypothalamus. Right? Satiety center is the ventromedial hypothalamus. Yes? Ventromedial hypothalamus. Satiety center, ventromedial hypothalamus. Then for sexual responses, hypothalamus is also the sexual responses. Vignesh, yes? Snickers ad. Okay. So sexual responses is also a function of the hypothalamus. Now, which part of the hypothalamus is involved? And that is sexual responses. This is going to be in the anterior most and posterior most portions of hypothalamus. Anterior most and posterior most portions of the hypothalamus. Right? These are involved in sexual responses. In males, there is an additional area, and that is known as the piriform cortex. In males, there is an additional area which is known as the piriform cortex. Yes, so this is involved in sexual responses, anterior most and posterior most portions of hypothalamus. And like I said, in males, there is an additional area which is known as the piriform cortex. Then also hypothalamus has a role to play in circadian rhythm. Circadian rhythm. Circadian rhythm. Which nucleus? This has been asked as a question. Sexual responses has been asked as a question. So for circadian rhythm, suprachiasmatic nucleus of hypothalamus. Suprachiasmatic nucleus of hypothalamus, right? This again for circadian rhythm. Circadian rhythm, you know, the sleep-wake cycles, secretion of hormones, these follow a circadian rhythm, and the nucleus of the hypothalamus is suprachiasmatic. Suprachiasmatic. So these are all the nuclei of the hypothalamus. Let's see them once again. T, functions and nuclei. T, temperature regulation. E, endocrine. So I said hypothalamus has 10 hearts. T, temperature regulation. E, endocrine. N, neuroendocrine function. H, it is the hunger center. Which part of the hypothalamus? Lateral hypothalamus. A is autonomic nervous system, periventricular areas of hypothalamus. R, rage center, lateral hypothalamus. Reward center, ventromedial hypothalamus. T is the thirst center, lateral hypothalamus. Like I told you, lateral hypothalamus has got overlapping functions. Hunger center, thirst center, rage center. This is, if stimulation of the lateral hypothalamus in experimental animal, hungry, thirsty, violent, aggressive, right? S is the satiety center. Now again, the satiety center is the ventromedial hypothalamus, and ventromedial hypothalamus is also the reward center. Yes, so the reward center. So if I use the stimulation of the ventromedial hypothalamus, what is going to be the response? Stimulation of the ventromedial hypothalamus in an experimental animal, what is going to be the response? This is, remember, it is the satiety center and the pleasure or the reward center. So the animal will be quiet, calm, quiet, isn't it? He's happy with himself, with the rest of the world, you know, so he's absolutely at peace with himself, right? So this is the ventromedial hypothalamus. Mohan Raj, yes, in general physics, baroreceptor, not baroreceptors, beta, osmoreceptors. Osmoreceptors. So you can have other things also, Mohan Raj. Anterior hypothalamus does not mean only osmoreceptors, isn't it? Okay? All right. So Mohan Raj, osmoreceptors, anterior hypothalamus, especially the OVLT area. OVLT area, right? Okay. Next, I wanted to discuss with you in detail what is the role of the hypothalamus in temperature regulation. Temperature regulation. Yes, temperature regulation, which is a function of the hypothalamus. Let's discuss this in detail. Swapnadeep Thale, yes, this is in humans. Oh, you mean to stimulate the lateral hypothalamus and ventromedial hypothalamus? Stimulation experiment. Would you like to do that? Do you want to introduce electrode in someone's brain? अच्छा, चलो ठीक है. Rohan Dev, if you want the stimulus, karo beta बैठ के. All right, पढ़ो. That is going to stimulate your reward center, isn't it? Okay, so temperature regulation. Now, temperature regulation is a very, very important function of the hypothalamus. Now, one point which I must clarify here is we did thermoreceptors. Yes. So a lot of people ask me, please remember the thermoreceptors which I did in sensory system with you. Thermoreceptors are meant for detection of objects placed on the skin. So these thermoreceptors are on the skin and mucosae. Understood? For example, the oral mucosa also has got thermoreceptors. Skin has got thermoreceptors, right? But temperature regulation is not a function of the thermoreceptors. The somatic thermoreceptors. Temperature regulation is a function of the hypothalamus, right? Now, hypothalamus, there are two parts of the hypothalamus. The posterior hypothalamus. Hypothalamus and the posterior hypothalamus. This is the cold. This is the heat gain center. Heat gain center. This is the posterior hypothalamus, which is the heat gain center. This is it responds to cold. Heat gain centers, it responds to cold. So this is going to be active in winters. This is active in winters, right? The posterior hypothalamus it is your heat gain center. It will be active in winters. It responds to cold. The second part of the hypothalamus, which is involved in temperature regulation, is anterior hypothalamus. This is the heat loss center. This is the heat loss center, right? Heat loss, anterior hypothalamus, including the preoptic nucleus. Including preoptic nucleus. If you look at old books and old knowledge, preoptic nucleus was thought to be for sexual activity. But today we know it is not. It is involved in temperature regulation. This is the heat loss center. This responds to warmth. This responds to warmth. In other words, the anterior hypothalamus is active in summers. This is going to be active in summers, right? It helps you to regulate the body temperature in summers. I remember this is in summers you need ACs. Yes, so anterior hypothalamus is going to be active in summers. It responds to warmth, right? So this is as far as the two areas of the hypothalamus are concerned. Posterior hypothalamus, heat gain center, anterior hypothalamus, including the preoptic nucleus. Like I said, older knowledge was preoptic nucleus is for sexual activity, but that's not true. Today we know which parts of the hypothalamus are involved in sexual activity, anterior-most and posterior-most portions of hypothalamus, and in males, an additional area which is called pyriform cortex. Now let's see what is the role of the posterior hypothalamus. How does it respond to cold? How does it help to gain heat? See, now what happens in winters is, now our core body temperature, we are at 37 degrees Celsius, right? We are at 37 degrees Celsius. Outside temperature, maybe let's say 10 degrees Celsius. Very cold. Core body temperature, 37 degrees Celsius, right? This is the core body temperature. Right? 37 degrees. Outside temperature is very low. Now, you know that heat has a tendency to move from warmer to colder objects. So, in winters, we are warmer, right? So, there is a tendency to lose heat. Now, my first important point is what is the major mechanism of heat loss in winters? Like I said, in winters there's a tendency to lose heat. Major mechanism, there are three mechanisms of heat loss: radiation, conduction, convection, radiation, right? So what is going to be the major mechanism of heat loss? The major mechanism of heat loss is radiation. Major mechanism of heat loss is by radiation, right? The moment we lose the heat by radiation, the core body temperature will tend to fall, right? We've lost heat mainly by radiation. There is a fall in the core body temperature, and when there is a fall in the core body temperature, the fall in the core body temperature will now activate the posterior hypothalamus, right? So there's a tendency to lose heat mainly by radiation, and loss of heat by radiation causes a fall of the core body temperature, and that in turn will stimulate the posterior hypothalamus. And when the posterior hypothalamus gets stimulated, there are three responses. Let's see the first response. First response is there is going to be an increase in the sympathetic discharge, which causes a peripheral vasoconstriction. It causes a peripheral vasoconstriction. And if there is a peripheral vasoconstriction, it reduces, it minimizes the heat loss. It minimizes heat loss, decreases the heat loss. Isn't it? There is a peripheral vasoconstriction. Very common experience in winters, especially in the north, right? When you touch your hands and feet, they're cold, isn't it? Because what has happened? There is a peripheral vasoconstriction which has taken place. And the reason for that is the moment there is a fall in the core body temperature, it stimulates the posterior hypothalamus. Posterior hypothalamus has increased the sympathetic discharge. It has caused a peripheral vasoconstriction, which now reduces heat loss from the extremities. Right? Your hands and feet are so cold, isn't it? And this is what you would common experience. Like I said, it helps to reduce the heat loss in winters. The second is what is called non-shivering thermogenesis. Non-shivering thermogenesis. Now, what happens in non-shivering thermogenesis? Increased sympathetic discharge. This acts on beta-3 receptors. This acts on beta-3 receptors in brown fat. It acts on beta-3 receptors in brown fat. There is release of norepinephrine, which acts on beta-3 receptors in brown fat. Where is the brown fat located? Where is the brown fat located? Brown fat is located in the nape of neck, in adults at least. In nape of neck, axilla, around the great vessels. This is where you get brown fat, right? Around the great vessels, veins, right? Around the great vessels. This is where you get brown fat in the case of an adult. Yes? In an adult, the brown fat is located in the nape of the neck, axilla, around great vessels. This is the place where you get brown fat. When beta-3 receptors are stimulated in brown fat, yes, in brown fat, it now causes uncoupling. There is an uncoupling of oxidative phosphorylation. There is an uncoupling of oxidative phosphorylation. Uncoupling of oxidative phosphorylation. And the reason for that is brown fat has got a specific protein which is called uncoupling protein 1, UCP1. This is present in brown fat, which is called uncoupling protein 1. So there is uncoupling of oxidative phosphorylation, and if there is an uncoupling of oxidative phosphorylation, this will now result in it causes an increase in the heat production, right? Beta-3 receptors in brown fat. Brown fat has got a special protein which is called UCP1, uncoupling protein 1, which results in uncoupling of oxidative phosphorylation and increases the heat production. So this is non-shivering thermogenesis. Now, is this mechanism important in adults? No. In adults, this mechanism is responsible for 10 to 15% of the total heat produced. 10 to 15% of the total heat produced is because of non-shivering thermogenesis. In adults, 10 to 15% of the total heat produced is because of non-shivering thermogenesis. So it is not an important mechanism in adults. This is an important mechanism in newborns, but not in adults, right? Non-shivering thermogenesis. Now, one important point which I want to lay stress is beta-3 receptors are also present in white fat. Beta-3 in white fat. But what is the effect of beta-3 stimulation in white fat? In white fat, it produces lipolysis. There is no uncoupling there. Beta-3 are present in white fat as well as brown fat. In brown fat, there is uncoupling of oxidative phosphorylation, but in white fat, it causes lipolysis. Okay? So this is an important point that you must keep in mind. Beta-3 is present in white fat as well, but it results in lipolysis. Now, the next important point here is, in non-shivering thermogenesis, a lot of people believe that we must include there is also increase in TRH. Yes, there is increase in TRH in cold, when in winters there is increase. What is TRH? Thyrotropin releasing hormone from the hypothalamus. That means basically it is trying to tell you non-shivering thermogenesis also includes the thyroid response, right? Also includes the thyroid response. But please understand there is increase in TRH in animals. We are not sure whether it happens in humans or not. Humans, we are not very sure, but in animals, yes. There is increase also in the thyroid response. There is increase in TRH in animals, but like I said, whether it is present in humans, we are not very sure. Okay? All right. Now, this was, to increase the heat production, in winters, what are the responses by the posterior hypothalamus? Number one, there is a peripheral vasoconstriction, which minimizes heat loss by radiation. Number two, non-shivering thermogenesis, which involves the beta-3 receptors in brown fat, uncoupling of oxidative phosphorylation, and increases the heat production. The third mechanism to be activated is going to be shivering. Shivering is the most important mechanism in adults. This is most important in adults. And this is not important, not well developed in infants, right? In infants, in newborns or infants. Okay. Are we clear with that? Right. So this is shivering, right? Now, see the TRH, Divya, what is the TRH response? TRH is thyrotropin releasing hormone. If there is increase in TRH from the hypothalamus, there will be increase in T3, T4 secretion. There is increase in TSH from pituitary and increase in T3, T4 from the thyroid. Now, a lot of people believe that is increase in thyroid response in winters. In animals, yes, we are sure. But does it happen in humans? We are not sure. So I've put a query in front of humans. Are we clear? So TRH's response is also a part of non-shivering thermogenesis. Okay? All right. What is the difference between uncoupling and lipolysis? Uncoupling of oxidative phosphorylation will produce heat. Lipolysis will cause increase in free fatty acids. Okay? All right. Yes, Vadha Arora. There is a lot of people say winters are tough on elderly, isn't it? Isn't it? Elderly, a lot of people say, because what happens is there is increased sympathetic discharge in winters. And elderly whose hearts are already sort of compromised, there are generally cardiac conditions associated in the elderly. So an increase in total peripheral resistance, increase in sympathetic discharge, increase in total peripheral resistance, puts an extra load on an already compromised heart. So that is why winters are so tough for the elderly. Okay. Now this is as far as what happens when you want to gain heat, what happens in winters. Let's have a look at what happens in summers. In summers, like I said, what is the heat loss center? Heat loss center is the anterior hypothalamus and including the preoptic nucleus, right? Preoptic nucleus. Okay? Okay? No, Jess, it does not mean loss of weight. Lipolysis means breakdown of lipids to generate free fatty acids. Not weight loss. There is no weight loss in winters. In fact, weight gain, because you tend to eat so much more, isn't it? Okay. All right, so anterior hypothalamus is the including preoptic nucleus. This is the heat loss center. It responds to warmth. So what happens in summers is, in summers the outside temperatures are very high. Again, I told you heat gain, the major mechanism. Now there is going to be a tendency to gain heat, isn't it? A tendency to gain heat because now outside temperatures are very high. And what is the major mechanism of heat gain? The major mechanism of heat gain is going to be radiation. Radiation is the major mechanism of heat gain. And when you gain heat by radiation, when you gain heat by radiation, the core body temperature will now rise. Core body temperature will now rise. Okay. So what happens if there is a rise in the core body temperature? This rise in the core body temperature will now excite, the rise in the core body temperature will excite the anterior hypothalamus, which is your heat loss center. And there is going to be increase in, now how do we lose heat during this time? Let's see. The first response is peripheral vasodilation. Peripheral vasodilation, right? Whenever there is an increase in the body temperature, peripheral vasodilation, isn't it? Now, for example, another area where you see not just summers, exercise. Exercise causes increase in the heat production, yes? Increase in body temperature, isn't it? There is increased heat production, there is increase because of increased metabolism, there is increase in body temperature, and you see there is going to be, what is going to be the response? There is a peripheral vasodilation. You have a nice cardio workout, you are looking all red, isn't it? Peripheral vasodilation is to increase the heat loss from the periphery, isn't it? So this is peripheral vasodilation, right? The second thing which is going to, whenever there is increase in body temperature, sweating. Sweating will be stimulated, isn't it? We've already discussed sweat glands are supplied by sympathetic cholinergic fibers, isn't it? So they are supplied by the sympathetic cholinergic fibers. So these are the two mechanisms which will be activated whenever there is a tendency to gain heat, right? Sympathetic cholinergic. All right. For heat loss and heat gain, major mechanism is radiation. Yes, both for heat loss as well as for heat gain. Heat loss, which happens in winters, major mechanism. I did not say only mechanism, it says major. Major mechanism will be radiation. In summers, there is a tendency to gain heat. Major mechanism will be by radiation. Of course, conduction and convection also plays a role. Okay? All right. Debashish Bishoy, what are you saying, beta? Exercise में heat loss होता है या heat gain होता है? Body temperature बढ़ता है या कम होता है? Debashish, body temperature बढ़ता है. Uncoupling of oxidative phosphorylation is when there is fall in body temperature. Have you understood? Right? What is shivering thermogenesis? Heat generated by shivering, isn't it? Heat generated by shivering. Muscle activity increases, right? Heat generated by shivering. Rohan Garg, what happens in exercise? When you're exercising, increased metabolic activity, there is increase in heat production, body temperature rises commonly. Agar exercise kiya ho to pata hai na? We as medicos tend to not exercise. So next time when you exercise, see what are the physiological changes which are taking place. There is increase in body temperature. So your face becomes red. There is a peripheral vasodilation. There is sweating. All that is because of the involvement of the anterior hypothalamus. Okay? How does TRH increase? Shilpa Chandran, the posterior hypothalamus will send stimuli to the arcuate nucleus from where TRH increases. Okay? Okay. White fat, beta, I told you white fat, beta-3 is present in white fat, which is whenever beta-3 in white fat is is stimulated, there is going to be lipolysis. Okay? All right. Okay. So this is as far as your temperature regulation is concerned. Let's have a look at what are the endocrine and the neuroendocrine function. Neuroendocrine, and one important point, please remember shivering. How does shivering take place? Posterior hypothalamus, which is your heat gain center. Heat gain center. Yes, heat gain center. It now sends impulses to the motor cortex, to the precentral gyrus. It sends impulses to the motor cortex, and there is increase in muscle activity. Increase in muscle activity. There is alternate contraction, relaxation. There is shivering which takes place, and that in turn gives rise to increase in the heat production. Right? Yeah. So, Tanya Roy, what is the role of hypothalamus in fever? Again, this is something which is done in pathology. There is, as far as the hypothalamus is concerned, there is a hypothalamic, there is a set point. Yes, there is a set point. Hypothalamus has a set point. What is a set point? Set point means our body temperature set point is 37 degrees Celsius. This is a set point in most individuals. This is the temperature set point. Yes. Now, in fever, what happens whenever there is an infection? The set point rises. Yes. Infection, because of macrophages, release of interleukin-1, there is a elevation of set point. There is an elevation of the set point. So if there is an elevation of the set point, I'm trying to tell you what happens in fever. Right? What is fever? Hypothalamus has got a set point. Normally, set point, this is normal. There is a normal set point, which is 37 degrees Celsius. Infection, because of interleukin-1 and prostaglandins, there is elevation of the set point. Yes, this elevation of set point means now instead of 37, it probably is 40 degrees Celsius. Okay? So once there is an elevation of the set point, now the posterior hypothalamus is activated. Posterior hypothalamus is activated. Isn't it? Because now the body must increase the temperature to this new set point, which is, let's say, 40 degrees. So the body needs to gain heat now. So shivering and rigors are so commonly seen. Have you understood? So posterior hypothalamus is activated. This now sets into motion shivering to increase the set point now to the new set point of 40 degrees Celsius. Have you understood? Right? So this is as far as your what happens in the case of fever. Please remember, there is a set point. This is normal, 37 degrees Celsius, which the body will always try to maintain the temperature at 37. Whenever there is infection because of release of interleukin and prostaglandins, there is an elevation of the set point. And when there is an elevation of the set point, the posterior height, now the new normal for the body is 40. So the posterior hypothalamus is going to be activated. And that sets into motion mechanisms to gain heat, and shivering is commonly seen, right? When we give NSAIDs, anti-inflammatory drugs, paracetamol and aspirin group of drugs, the set point is brought down back to 37. So what happens is now the body must lose heat to come back to 37. So sweating. Have you got it? Right? So this is what is okay. All right. So this is as far as what happens in fever. Okay. Now, the next important point that we are going to take up is Next important point that we're going to take up is let's see what is the endocrine and neuroendocrine function. Oh, Akshada Bala Subramaniam, let me just clarify this once again. Please remember, what happens in infections is elevation of the set point. Elevation of set point means now the posterior hypothalamus is activated. So body must gain heat to increase the temperature to 540, right? There is increase in heat production. There is increase in heat production, and that increases the body temperature. Akshada, just see this please. Akshada Bala Subramaniam, there is increase in body temperature, which is now called fever. Okay? Which is now called fever. Right? So the posterior hypothalamus is going to be activated. There is shivering, there is increase in heat production, increase in the body temperature, fever. Now what happens is, yes, now when you give paracetamol, yes, when you give paracetamol, there is lowering of set point. There is lowering of set point. So now sweating, which reduces the body temperature. Right? Sweating would be anterior hypothalamus. Right? So this is as far as your temperature regulation is concerned. Okay. All right. Let's have a look at the next one. Yes, Ajinkya, absolutely right. Okay. Mansi Gurpare, good mornings. We are trying to complete the central nervous system. All right. So let's see what are the endocrine and neuroendocrine functions of the hypothalamus. Endocrine and neuroendocrine function of hypothalamus. Endocrine and neuroendocrine function of the hypothalamus. Okay. Now, when I look at the neuroendocrine and endocrine function of the hypothalamus, let's see this. Right? Now, when I say neuroendocrine, there are two important nuclei of the hypothalamus which are going to be involved. Two important nuclei of the hypothalamus which are involved, right, for neuroendocrine function of the hypothalamus, and that is supraoptic and paraventricular nuclei. Supraoptic and the paraventricular nuclei of hypothalamus. Yes. These are your neuroendocrine function of hypothalamus, supraoptic and paraventricular nuclei. These are involved in secretion of ADH and oxytocin. ADH and oxytocin. 5/6 of ADH comes from supraoptic and 1/6 comes from paraventricular. Oxytocin is reversed. 5/6 comes from paraventricular and 1/6 from supraoptic, right? So ADH and oxytocin, supraoptic nucleus, 5/6 of ADH comes from supraoptic, 1/6 from paraventricular, oxytocin, reverse, yes? Now, these are synthesized in the posterior hypothalamus, they are synthesized in the hypothalamus as large precursor molecules. Then they reach the posterior pituitary, and from the posterior pituitary, they come into the circulation. They come into the circulation, right? Synthesized in the hypothalamus, transported by axoplasmic transport into the posterior pituitary, and then released into the circulation from the posterior pituitary, right? They are ADH and oxytocin are synthesized as large precursor molecules. large precursor molecules, transport by axoplasmic transport, transported to the posterior pituitary, and from there they are released into the circulation as free. They are released as free ADH and oxytocin, free ADH and free oxytocin. Yes, so please remember, this is the neuroendocrine function. These two hormones are synthesized in the supraoptic and the paraventricular nuclei of hypothalamus, and from here transported by axoplasmic transport into the posterior pituitary, and from there released into the circulation as free ADH and free oxytocin. Right? So this is neuroendocrine function. This question has been asked. Oxytocin is mainly secreted from which nucleus of hypothalamus? And your answer is paraventricular. Paraventricular. I remember this as Om Prakash. O oxytocin, P paraventricular. So oxytocin is mainly paraventricular, ADH is mainly supraoptic. Now let's see what happens in the case of the what happens in the case of the anterior pituitary hormones. Now, as far as anterior pituitary hormones are concerned, they are under the control of releasing and inhibiting hormones secreted from the hypothalamus. Yes, they are under the control of releasing and inhibiting hormones from the hypothalamus. These releasing and inhibiting hormones, they enter into. Okay, Shiv Shankar, I'll keep that in mind. They enter into what is known as the hypophyseal portal system. They enter into the hypophyseal portal system. Okay. Hypophyseal portal system, and then to the anterior pituitary. So which are the two nuclei which are involved? The two nuclei which are involved are, number one is the paraventricular nucleus. Paraventricular nucleus. Paraventricular nucleus secretes CRH, corticotropin releasing hormone, enters into the hypothalamo-hypophyseal portal system, and it goes into the anterior pituitary and increases the ACTH secretion. Right? Then it also secretes TRH, which enters into this portal system, goes into the anterior pituitary, increases the secretion of TSH. CRH is corticotropin releasing hormone. TRH is thyrotropin releasing hormone. These are both from the paraventricular nucleus of hypothalamus. Then you have the arcuate nucleus. Arcuate nucleus. Arcuate nucleus is involved in the secretion of GnRH, gonadotropin releasing hormone, which increases the secretion of FSH in the anterior pituitary. It increases the secretion of FSH and LH from the anterior pituitary. Right? Gonadotropin releasing hormone. Then you have the GHRH, growth hormone releasing hormone. Growth hormone releasing hormone, which increases the secretion of growth hormone from the anterior pituitary. Right? The two nuclei which are involved in secretion of releasing and inhibiting hormones, paraventricular and arcuate nucleus. Arcuate nucleus. Arcuate is secreting GnRH, gonadotropin releasing hormone, which enters into the hypothalamo-hypophyseal portal system, increases FSH-LH. GHRH, growth hormone releasing hormone. It goes into the, again, hypothalamo-hypophyseal portal system to the anterior pituitary, increases secretion of growth hormone from anterior pituitary. Two inhibiting hormones. which are the inhibiting hormones which are secreted by the arcuate nucleus, and that is somatostatin, which decreases growth hormone secretion. And number 4 is prolactin inhibiting factor, which reduces the secretion of prolactin. This is as far as your complete the endocrine function of hypothalamus is concerned. Arcuate nucleus and paraventricular. Paraventricular secretes CRH and TRH, which goes via the hypothalamo-hypophyseal portal system into the anterior pituitary. Arcuate nucleus is secreting GnRH, GHRH, somatostatin, and prolactin inhibiting factor. Right? Supraoptic and paraventricular nucleus of hypothalamus are involved in neurosecretion. 5/6 of ADH from supraoptic, 5/6 of paraventricular from of oxytocin from paraventricular. 5/6 of ADH from supraoptic, 1/6 from paraventricular, 5/6 of oxytocin from paraventricular, 1/6 from supraoptic. Okay. This is as far as your endocrine and neuroendocrine secretion of the hypothalamus is concerned. Endocrine and neuroendocrine secretion of the hypothalamus. Now please see this. I'm just writing this once again, and that is the corticotropin releasing hormone from the hypothalamus will increase the ACTH secretion from the pituitary. TRH from the hypothalamus will increase TSH from the anterior pituitary. GnRH from the hypothalamus will increase FSH and LH from the anterior pituitary. Growth hormone releasing hormone will increase growth hormone secretion from the anterior pituitary. Somatostatin decreases, it inhibits the secretion of growth hormone from the anterior pituitary. Prolactin inhibiting factor, which is dopamine, this prolactin inhibiting factor or dopamine will now reduce prolactin secretion from the anterior pituitary. So this is your hypothalamo-pituitary axis. CRH from the hypothalamus will increase ACTH. CRH and TRH are secreted by the supraoptic nucleus of hypothalamus. Supraoptic nucleus of hypothalamus. Yes. GnRH, GHRH, somatostatin, prolactin from the arcuate nucleus of hypothalamus. Right? Sorry, not supraoptic, paraventricular. Sorry, paraventricular nucleus of hypothalamus. Yes. So these are your, like I said, arcuate nucleus, GnRH, GHRH, somatostatin, prolactin inhibiting factor. But please understand, the major hormone which controls the growth hormone secretion from the anterior pituitary is GHRH, not somatostatin. GHRH, not somatostatin. Yes? Now, if there is an accidental transection of the pituitary stalk, what is known as the stalk effect. What is stalk effect? Stalk effect is if there is a transection of the pituitary stalk. In stalk effect, there is going to be increase in prolactin secretion. There is an increase in the prolactin secretion. Okay, understood? All other hormones of the anterior pituitary will be reduced. There is decrease in ACTH, decrease in TSH, decrease in FSH, LH, decrease in growth hormone, but increase in prolactin. This is known as the stalk effect, and this question has been asked a number of times. Yes, in stalk effect, there is going to be, if there is a transection of the pituitary stalk. right? If there is a transection of the pituitary stalk, that means like this. If I see the pituitary stalk here, if this is damaged, which of the hormones is going to increase? And that is prolactin. Prolactin will show an increase. One small point here, all hypothalamic hormones are secreted in a pulsatile fashion. All hypothalamic hormones are secreted in a pulsatile fashion, right? All hypothalamic hormones are secreted in a pulsatile fashion except TRH. Important question here, except TRH. All hypothalamic hormones are secreted in a pulsatile fashion except TRH. So this is one important point here. Next important point. Gonadotropin releasing hormone. It is released in a pulsatile fashion, isn't it? A low frequency pulse. GnRH, which I said is secreted in a pulsatile fashion, a low frequency pulse will increase FSH. And GnRH in a high frequency pulse increases LH. I told you all hypothalamic hormones are secreted in a pulsatile fashion, not a steady, right? It's in a pulsatile fashion. All hypothalamic hormones are secreted in a pulsatile fashion except TRH. GnRH, second important point, GnRH in a low frequency pulse will increase FSH, but in a high frequency pulse will increase LH, right? LH. This is as far as your the hypothalamic hormones is concerned. Okay? See, there was a question which was asked. A continuous IV infusion of GnRH. Continuous IV infusion of GnRH increases FSH, LH, or does it decrease FSH, LH? Right? Continuous IV infusion of GnRH, does it increase FSH, LH, or does it decrease the FSH, LH? In fact, continuous IV infusion will reduce FSH, LH. Remember, it has to be, GnRH has to be in a pulsatile fashion. Right? It has to be secreted in a pulsatile fashion, not a continuous or a steady level. Right? So this is continuous IV infusion of GnRH. What does it do? It causes a down regulation. It causes a down regulation of the GnRH receptors. GnRH receptors on the anterior pituitary. Down regulation of the GnRH receptors in the anterior pituitary, which in turn decreases FSH, LH. Okay? Which decreases FSH, LH. Okay? So this is as far as your hypothalamus is concerned, and what are the different functions of hypothalamus. I told you hypothalamus has got 10 halves. Temperature regulation, we've done that in detail. Endocrine, neuroendocrine, hunger center, autonomic nervous system, rage center, reward center, temperature regulation, sexual activity, satiety center, and your circadian rhythm. Okay? All right. Next, let's go on to another important part in this chapter, and that is EEG. Let's see EEG. Electroencephalography, right? EEG. Now, as far as EEG is concerned, this is an important way to remember EEG is the different waves of the EEG is D, tau, delta, theta, alpha, beta. These are the four waves which are important as far as EEG is concerned. That is delta, theta, alpha, beta. Now, as you go from delta to beta, there is a decrease in the amplitude. There is a decrease in the amplitude and there is an increase in frequency, right? Decrease in amplitude and increase in frequency, yes? That means delta has got the largest amplitude, least frequency, largest amplitude. Beta has got the least amplitude and the highest frequency. Delta, theta, alpha, beta, right? Beta, as you go from delta to beta, there is a decrease in amplitude, but an increase in frequency. Delta are very large amplitude waves, but with low frequency, right? Beta are low amplitude, but high frequency. And to remember the different frequencies, remember your table of 4. 4 ones are 4, 4 twos are 8, 4 threes are 12, 4 fours are 30. Okay? This is your new 4 ka table. Okay? 4, 8, 12 and 30. So what is the frequency? Delta has a frequency of less than 4 hertz. This is 1 to 3 hertz. Delta has a frequency of less than 4 hertz, 1 to 3 hertz. Theta has a frequency of 4 to 7 hertz. Alpha has a frequency of 8 to 12 hertz. And beta has a frequency of 13 to 30 hertz. So that is why 4, 8, 12, 30. Right? 4, 8, 12, 30. Delta is high amplitude, low frequency. Beta is low amplitude, high frequency. Arpan Patel, kya galat hai beta? Arpan, what is wrong in the diagram? Okay. Delta is high amplitude, low frequency. Beta is low amplitude, high frequency. So delta is less than 4 hertz, 1 to 3 hertz. Theta is 4 to 7 hertz. Alpha is 8 to 12 hertz. And beta is 13 to 30 hertz. Okay? Right? So now let's have a look at delta. Now, first let's discuss a little bit about delta rhythm. The delta rhythm, like I said, is high amplitude, low frequency. See, low frequency means there will be wider waves. Have you understood? Low frequency means there will be less number of cycles in 1 second. So they'll be short, they'll be wide. Have you understood? Low frequency and high amplitude and low frequency. Now, delta, the origin of the delta rhythm, origin of the delta rhythm, this is going to be the cerebral cortex. Cerebral cortex. Origin is going to be the cerebral cortex, but they occur, the delta rhythm occurs independent of activity in the lower areas, independent of activity in the lower areas, right? The origin is going to be the cortex and they occur independent of activity in the lower areas. See, lower areas I mean is, for example, reticular formation. We've discussed this briefly. If you remember when I was telling you about pain and I told you reticular formation has a role to play in keeping you awake, isn't it? Locus coeruleus, raffinagmus nucleus, remember that, right? So remember, the beta rhythm is dependent on activity of, this is dependent on activity of the lower areas. This is dependent on activity of the lower areas. And when I say lower areas, that is, for example, like I said, the reticular formation. It is dependent on the activity of the lower areas, for example, the reticular formation. Remember that ascending reticular activating system causes a generalized activation of the cerebral cortex. That is responsible for beta rhythm. But delta is independent of activity of the lower areas, right? So keep that in mind. Delta is going to be independent of activity of lower areas. So when do I record delta? Delta rhythm is present. Delta is present in deep sleep. Delta is present in deep sleep, stages 3 and 4 of NREM sleep. Stages 3 and 4 of NREM sleep, present in deep sleep. Right? Delta is present in infants. RF is reticular formation. We've done this already, beta. Ashwini, I've been saying that reticular formation, ascending reticular activating system. Now, delta is present in deep sleep, stages 3 and 4 of NREM sleep in infants. Delta can also be recorded in serious organic brain disorders. Serious organic brain disorders. Serious organic brain disorders. Then these can also be recorded in patients of encephalopathy. Encephalopathy. Right? So delta rhythm can be recorded in deep sleep, stages 3 and 4 of NREM sleep in infants. These are normally recorded in deep sleep and in infants. Also in serious organic brain disorders and in encephalopathies. This is delta. Delta, like I said, low frequency and high amplitude. These are very easy to pick up on EEG. They are the tallest waves and the widest waves. Tall, high amplitude, low frequency waves. Then the next one was theta. And theta, if you remember, we wrote 8. Delta was 4, theta is 8. So that means this is 4 to 7 hertz. 4 to 7 hertz. The origin of the theta rhythm, this is going to be the hippocampus. Hippocampus. Origin is going to be the theta rhythm. And this is hippocampus. Okay? Theta are recorded in emotional states. This is recorded in emotional states. These are recorded in moments of disappointment, in moments of frustration, and in children when they are crying. Children when they are crying. This is when you get the theta rhythm, emotional states, disappointment, frustration, children when they are crying. Which are the waves which are prominent during lockdown? Theta rhythm. No, I'm just joking. This is emotional states, disappointment, frustration, children when they are crying. Okay? This is what is known as the theta rhythm. Then you have the alpha. Alpha is 8 to 12 hertz. 8 to 12 hertz. Alpha will be recorded when you are at rest, awake, eyes are closed, and mind is wandering. Eyes are closed and mind is wandering, right? Rest, awake, eyes closed, mind wandering. That means you are not thinking of anything or anyone. That is the time when you get the alpha rhythm. Rest, awake, eyes closed, and mind wandering. The moment you start thinking, even if your eyes are closed and you start thinking of someone or something, the frequency of alpha rhythm will increase. Have you got it? Right? So this is at rest, awake, eyes closed, mind wandering. This is the time when you get the alpha rhythm. Remember, eyes have to be closed. In class, mind wandering, that is not alpha. Eyes are open, that is not alpha. And that's true. This is alpha, is eyes closed, mind wandering. You are not thinking of anything or anyone. Okay? The moment you open your eyes are opened. The moment you open your eyes, alpha will be replaced by beta. Alpha is replaced by beta. These are 13 to 30 hertz. 13 to 30 hertz. Right? Eyes, the moment eyes are opened, it will be replaced by a beta rhythm. Beta rhythm is 13 to 30 hertz. And this alpha being replaced by beta rhythm, this is called the alerting response. Alpha being replaced by beta, this is known as the alerting response. This is alerting response, also known as, this is known as the alerting response. It is also known as arousal. Arousal. It is also known as alpha block. This is known as alpha block. So alerting response, arousal, and alpha block by beta. Right? The moment you start, this is eyes are open. Alpha is replaced by beta. The moment you focus on something, if I ask you to focus on something, then beta is replaced by gamma oscillations. This is replaced by gamma oscillations. And what are these gamma oscillations? Gamma oscillations are very high frequency activity. These are 30 to 80 hertz. 30 to 80 hertz. Please see this once again. When do we get an alpha rhythm? Rest, awake, eyes closed, mind wandering. Right? Mind wandering, puja, means not thinking of anything in particular. Yes? Not thinking of anything in particular. That is mind wandering. Right? The moment you open your eyes, beta. Beta is 13 to 30 hertz. The moment you focus on something, beta is replaced by gamma oscillations, and gamma oscillations are very high frequency activity, 30 to 80 hertz. Right? 32. Origin of alpha and beta are both the cortex. You're recording them from the cortex, but the conditions are different. Eyes closed, and here it is eyes open. Now, the frequency, now another important point here, and that is the frequency of alpha rhythm. Frequency of alpha rhythm decreases in the following conditions. Frequency of alpha rhythm decreases. Normal frequency of alpha rhythm, 8 to 12 hertz. But in the following conditions, there is a decrease in the frequency of alpha rhythm. Now, what are the conditions which will cause a decrease in frequency of alpha rhythm? Hypoglycemia. Hypoglycemia, a decrease in the blood sugar level. Hypoglycemia. Hypothermia. Hypothermia. Decrease in body temperature. Hypocortisolism. Hypocortisolism. Decreased secretion of glucocorticoids. Decreased secretion of glucocorticoids. And increase hypercarbia or hypercapnia. That means increase in PaCO2. Please remember, these are the conditions which will cause a decrease in frequency of alpha rhythm. That means here is your patient who is lying down, rest, awake, eyes closed, mind wandering. But instead of getting a 8 to 12 hertz activity, you are getting a lower frequency activity. What are the conditions? Hypoglycemia, hypothermia, hypocortisolism, and also hypercarbia. Then also in alcohol intoxication. Alcohol intoxication. Then alcohol intoxication with phenytoin, barbiturates, and encephalopathies. These are the conditions where the frequency of alpha rhythm will reduce, right? Frequency of alpha rhythm decreases in which of the following conditions? Hypoglycemia, hypothermia, hypocortisolism, hypercarbia. Also in alcohol intoxication, phenytoin, barbiturates, encephalopathies. The frequency of alpha rhythm will decrease. Instead of getting 8 to 12 hertz activity, when you are at rest, awake, eyes closed, mind wandering, you get a lower frequency activity, right? This is the okay. Now, so this is as far as your these waves are concerned. We've discussed delta, deep sleep, infants, serious organic brain disorders, encephalopathies, theta, origin hippocampus, emotional states, disappointment, frustration, and in children when they are crying. Alpha, rest, awake, eyes closed, mind wandering, and beta, 13 to 30 hertz, and gamma oscillations, 30 to 80 hertz. Let's see what are the EEG waves. In Berger waves are the alpha rhythm. Alpha rhythm is called the Berger waves. Right? Alpha rhythm is called the Berger waves. Also known as the Berger waves. These were because EEG was discovered by Hans Berger. Right? Now let us see what happens. What happens? What are the EEG in sleep? Let's see the EEG in sleep. What is the sleep cycle and what is the EEG which are seen in sleep? Right? EEG waves. These are in sleep. Right? Okay. Okay. Now, like I said, when you are at rest, you are awake, eyes closed, mind wandering, right? You have decided you're going to sleep and you've closed your eyes, your mind is wandering. This is the time when you get the alpha rhythm. And alpha rhythm, DTAP 4, 8, 12. So this is 8 to 12 hertz activity. Please remember, mind wandering means you're not thinking of anything or anyone. The moment you start thinking of something or anyone or someone, the frequency will increase. Right? So rest, awake, eyes closed, mind wandering, and this is when you get the alpha rhythm. Yes. Now, the moment you close your eyes, yes, the moment you close your eyes, the moment you now when you begin to sleep, the first you go into what is known as stage 1. Stage 1 of NREM sleep. Right? Stage 1, this is known as the stage of dozing. Stage of dozing. So as you go from awake to stage 1, there is a decrease in the frequency of alpha rhythm. There is a decrease in the frequency of alpha rhythm. Right? If there is a decrease in the frequency of alpha rhythm, Now, the waves which have got a frequency lower than alpha is theta. So we say in stage 1, we get stage 1 of NREM sleep, we get a theta-like activity. We will get a theta-like activity. Why theta-like activity? Because this is not a typical theta rhythm. I told you theta is in disappointment, emotional states, frustration. This is not stage 1, stage of dosing is definitely not that. But the wave, the frequency of alpha rhythm has reduced. So we call it theta-like activity. Understood? Theta-like activity. Now, from here, he goes into stage 2 of NREM, right? He goes into, after stage 1, we go into stage 2 of NREM. And stage 2 of NREM is characterized by sleep spindles. There are sleep spindles. Sleep spindles, these are 30 to 15 hertz activity, sleep spindles, and K complexes. What is a K complex? K complex is a biphasic wave. Stage 2 is characterized by sleep spindles, which are 13 to 15 hertz activity, and K complexes. When I say K complex, it has a biphasic. Biphasic means it has a positive component, it has a negative component. That is why you call it a biphasic wave. Stage 1, like I said, which is going to be a biphasic. Stage 2 is sleep spindles and K complexes. Then stage 3, he goes into stage 3 of NREMs. In stage 3, delta will make an appearance. Delta makes an appearance. Then he goes into stage 4 of NREM, where delta becomes even more prominent. Right? Stage 4 of NREM, where delta becomes even more prominent. Then goes back into stage 3. Then he goes back into stage 3, stage 2. He goes into a lighter stage of sleep. From 4, he goes back to 3, then 2, and then he goes into REM, rapid eye movement sleep. Rapid eye movement sleep, which is also known as the paradoxical sleep. Yes, rapid eye movement sleep, which is also known as the paradoxical sleep. Why paradoxical sleep? Because the wave that you see in REM is beta. And normally, I just told you, when do you see beta rhythm is when you are alert and awake. Here you are sleeping, but the rhythm which is being recorded is the beta rhythm. That is why REM is also known as paradoxical sleep. This occurs the duration of REM sleep is 5 to 30 minutes. After he completes his REM sleep, he goes back into stage 2, and then he goes back into stage 2, and then 3, 4, 3, 2 REM. This is a sleep, the 2, 3, 4, 3, 2 REM. This 90 minutes, every 90 minutes. This is known as your sleep cycle. Right? Let's see once again, what are the EEG recorded in different stages of sleep? Let's see this. You are at rest, awake, eyes closed, mind wandering, alpha rhythm, 8 to 12 hertz. Now you go into the first stage is stage 1 of NREM, which is the stage of dosing. During this time, the frequency decreases from alpha to theta-like activity. From stage 1, you go into stage 2 of NREM. Stage 2 of NREM is characterized by the presence of sleep spindles. Sleep spindle means a short duration of high frequency activity, which is 13 to 15, and also K complexes. K complexes are biphasic waves. Then you go to stage 3, which is delta. Stage 4, deep sleep, delta is plus plus. Then you go back into lighter stages of sleep, 3 to REM. REM is also known as a paradoxical sleep, because during REM, the waves recorded are beta, so it is known as a paradoxical sleep. Right? So this is okay. All right. So this is as far as your the EEG in sleep is concerned. Let's have a look at what are the neurotransmitters associated with sleep. Right? Neurotransmitters associated with sleep. Neurotransmitters in sleep. Divya Sharma, if you have a high frequency, low amplitude activity, Divya Sharma, high frequency, lower is like this now. High frequency, low, this is beta rhythm. It looks like a sawtooth. एक ही तो बात है, just the description is different. Duration of REM is 5 to 30 minutes, variable. ठीक है? Okay. All right, so let's see what is the neurotransmitters in, not in teeth, sorry, in sleep. Okay. Now, what are the neurotransmitters which are associated with sleep? No, I was trying. Okay. Now, we've already discussed this. So if you, the best way to remember awake state. No, my mind is not wandering. I was thinking of sawtooth activity. Somebody had written, you all distract me with your comments. Okay? And so many of you are asking such philosophical questions today. So, all right. Awake state. So let's write awake here. And here is REM. REM and NREM on this side. Oh, NREM is 90 minutes. Oh, sleep cycle is 90 minutes. Yeah, so sleep cycle means all the cycles, stages 2, 3, 4, 3, 2. All that will be 90 minutes. So NREM, awake state. So I've written this, awake is in the center, REM on the one side, opposite to awake state, NREM on the other side, opposite to awake state. Now, which are the neurotransmitters which are associated with the awake state? This I've already discussed with you. When I was discussing pain, I told you two important areas of the of reticular formation, which are involved with awake state, is the Rapamycus nucleus and locus ceruleus. So awake state is associated with increase in norepinephrine, increase in serotonin, isn't it? Norepinephrine comes from locus ceruleus. I've discussed this with you already. And serotonin is Rapamycus nucleus. raffinized status, right? So awake state is associated with increase in norepinephrine, increase in serotonin. REM, which is opposite, complete opposite, this is associated with decrease in norepinephrine and decrease in serotonin. Decrease in norepinephrine and decrease in serotonin. Okay. Now, REM is also associated with increase in acetylcholine. Why increase in acetylcholine? The reason is in REM sleep, there is something called PGO on cells, PGO on cells, and these are cholinergic. These are cholinergic. What is PGO? This is ponto. This is pontogeniculo occipital. Pontogenic. These are called your PGO on cells. Pontogeniculo occipital. PGO on cells, they give rise to what is known as the PGO spikes. Pontogeniculo occipital spikes. Pontogeniculo occipital spikes. Right? What is these pontogeniculo occipital spikes? These are a burst of electrical activity. This is a burst of electrical activity which starts from the pons, goes to the lateral geniculate body, and from there to the occipital cortex. Occipital cortex. It's a burst of electrical activity which starts from the pons. It goes to the lateral geniculate body, and from there to the occipital cortex. These are called PGO spikes. These are seen in REM sleep. REM sleep, two important electrical activities: beta rhythm, PGO spikes. Yes, REM sleep, like I said, two important things are seen in REM, and that is REM, two important electrical REM sleep, beta rhythm, beta, and PGO spikes. What are these PGO spikes? Let's see them once again. PGO spikes is a burst of electrical activity, which starts from the pons, goes to the lateral geniculate body, and from there to the occipital cortex. What is responsible for PGO spikes? PGO on cells, which are cholinergic. This question has been asked. Which neurotransmitter is associated with PGO spikes? Your answer is acetylcholine, right? The neurotransmitter associated with PGO spikes is acetylcholine. These are from PGO on cells, which are cholinergic. Now, in awake state, which is complete opposite of REM, there is decrease in acetylcholine. So try to remember this. Awake state, increased norepinephrine, increased serotonin. REM sleep, decreased norepinephrine, decreased serotonin. Awake state, decrease acetylcholine. REM sleep, increase acetylcholine. I've already told you what is the significance of this increased acetylcholine. This comes from PGO on cells and responsible for PGO spikes. Let's see NREM and the awake state. Let's see what's going to be the differences, what happens in NREM and awake state. Now, in NREM sleep, the hypothalamus from the hypothalamus, there is now increase in GABA and decrease in histamine. GABA is an inhibitory neurotransmitter, and there is a decrease in histamine. These now cause a deactivation. of thalamus and cortex. So in NREM sleep, there is increase in GABA and a decrease in histamine, which causes deactivation of the thalamus and the cortex. And how do you remember this? Antihistaminics are sedating, isn't it? Antihistaminics are sedating, right? So in NREM sleep, there is increase in GABA and a decrease in histamine. Together, they cause a deactivation of the thalamus. They cause a deactivation of thalamus and the cortex. And like I said, antihistaminics are sedating. So in the awake state, there is a decrease in GABA and increase in histamine. There is a decrease in GABA and increase in histamine. Ulta, opposite. Have you understood? See, the easiest way to remember this is follow this little chart. Awake is in the center. REM and awake are opposite. NREM and awake are also opposite to each other. Awake state, increase in norepinephrine, increase in serotonin, decrease in acetylcholine. REM sleep, decrease in norepinephrine, decrease in serotonin, increase in acetylcholine. Where does this acetylcholine in REM sleep come from? This comes from PGO-on cells. What are these PGO-on cells? Divyani, pay attention now. PGO-on cells are pontogeniculo-occipital on cells, like switch on. When they are switched on during REM sleep, there is release of acetylcholine. These cells are responsible for an electrical activity which is known as PGO spikes, pontogeniculo-occipital spikes. Burst of electrical activity which starts from the pons, goes to the lateral geniculate body, and from there to the occipital cortex. Then, hypothalamus, there is increased GABA, decrease, in NREM sleep, there is increase in GABA, decrease in histamine. Awake state, decrease in GABA, increase in histamine, right? Opposite to what you have seen in the NREM sleep. So these are the neurotransmitters associated with sleep. Okay? All right. Now, the last topic which I'm taking up are a Swapnil, Raut. I've written it over. Pontogeniculo-occipital cells means other pons. Swapnil, pay attention, beta. Okay. Now, the last part which I'm taking up in CNS, and that is the differences between NREM sleep and REM sleep, right? Differences between NREM and REM sleep. Okay. Now, as far as the yes, Harshita, melatonin, suprachiasmatic nucleus, which is involved in also in circadian rhythm, melatonin from pineal gland. Yes. Okay. Now, REM sleep, this is also known as the paradoxical sleep. This is NREM, also known as restful sleep. Why restful sleep? Because during this time, the heart rate, the blood pressure, the respiratory rate, all of these will reduce. So NREM is a restful sleep. REM is also known as a paradoxical sleep. This is also known as a paradoxical sleep. Why is it known as a paradoxical sleep? Because, number one, why is it known as a paradoxical sleep? Because number one, you get beta rhythm. In REM, you get beta rhythm. What is beta rhythm? It is recorded when you are awake and alert. Here you are sleeping and you're still recording a beta rhythm. Beta rhythm is low frequency, low amplitude and high frequency. Low amplitude, high frequency activity, which I've already discussed it with you. And this is also gives the sawtooth appearance. So they look like that sawtooth appearance. Everybody's been bothering about sawtooth appearance. Nothing like it. It's just low amplitude and high frequency. This has a sawtooth appearance. So this is known as a paradoxical sleep because, number one, a beta rhythm is being recorded. And beta is recorded when you are normally in the alert awake state. So it's paradox. Second important paradox. The rhythm that you get is beta, but the threshold for awakening is elevated. Threshold for awakening is elevated in REM sleep. Again, another paradox. You're getting a beta rhythm, but it is difficult to wake up a person in REM sleep. Threshold for awakening is elevated. So another paradox. Let's see the third paradox. Third paradox is spontaneous awakening. Spontaneous awakening. Spontaneous awakening usually occurs in REM sleep. Spontaneous awakening usually occurs in REM sleep. So these are the three important paradoxes here. Number one, in REM sleep, you are getting in REM sleep, you get a beta rhythm, which is normally recorded in the alert awake state. Threshold for awakening is elevated. Difficult to wake up a person from REM sleep, but spontaneous awakening usually occurs in REM sleep. When I say spontaneous means without the alarm, without your mother shouting at you, that is spontaneous, right? That is in spontaneous awakening usually occurs in REM sleep. In the morning, you usually get up in REM sleep. Then another paradox, this is a period of autonomic instability. REM sleep is autonomic instability. What is autonomic instability? Here the heart rate, blood pressure, respiratory rate, they become highly irregular. It is an autonomic instability. Heart rate, blood pressure, respiratory rate become highly irregular, right? Erections, these penile erections are also common during this phase, right? So this is autonomic instability, another paradox. Sleeping, but all these become highly irregular, right? This is now, and another important point here is, when I say autonomic instability, see, this is not a restful sleep. Which is a restful sleep is NREM, right? This is, like I said, this is a period of autonomic instability. Next important difference between NREM and REM sleep. In NREM sleep, yes, NREM, we are discussing NREM and REM sleep. NREM is considered somnambulism. Somnambulism is sleepwalking. This happens in NREM, right? Sleepwalking, somnambulism. Somniloquy, sleep talking. Nocturnal enuresis. Please, all of you, do not ask me the reason why is all this happening. These are observations of NREM and REM. When you become researchers, you can please find out how this happens. But for this moment, these are observations of NREM and REM sleep, differences between NREM and REM sleep. Why it happens, this is something which you can later on research. All right. Nocturnal enuresis, bedwetting. This is in NREM sleep. Bruxism. Bruxism is teeth grinding. NREM sleep. Night terrors. What are night terrors? Night terrors are dreams which you cannot remember. That dreaming will happen in NREM and REM, but in NREM you cannot remember. What you can remember are called nightmares. Nightmares are what you can remember. You know, the dreams which sort of which terrified you in sleep, which you can remember is in REM sleep. What you cannot remember is in NREM sleep, right? This is can remember is NREM, is REM sleep. Night terrors and nightmares. Somnambulism, sleepwalking. Somniloquy, sleep talking. Nocturnal enuresis, bedwetting. How do I act it out? I don't know. Bruxism, teeth grinding. Night terrors is what you cannot remember, and nightmares is what you can remember. Bruxism, teeth grinding. Okay. Narcolepsy is not physiological, Pashupati. I'm not going to talk about it. Okay? Okay. But a threshold for awakening is elevated, matlab difficult to wake up a person in REM sleep. Okay? Kitni baar hota hai subah aapko aapki mom is shouting, you can hear, but you just can't open your eyes. That is probably you're in REM sleep. But spontaneous awakening, jab apne aap uthte ho, without the alarm, without anybody shouting at you, that is usually in REM. Tabhi to isko paradoxical sleep bolte hain. Ye sab paradoxes hain. Samajh aa gaya? Okay. Then another important point in the in REM sleep is tone of neck muscles. Tone of markedly reduced in REM sleep. Tone of neck muscles. Left side wale points NREM ke hain, right side wale REM ke hain, right? All right. Now the tone of the neck muscles is markedly reduced in REM sleep, right? Again, a common experience when you're traveling in the bus. The fellow who's sitting next to you, what happens to his head after some time? Topples like this, isn't it? He goes into REM sleep. Tone of the neck muscles is markedly reduced. This is typically seen in REM sleep. REM sleep. All right. Next, in REM sleep, there is a locus ceruleus mediated. There is a locus ceruleus mediated relative paralysis. There is a locus ceruleus mediated relative paralysis which is seen in REM sleep. Right? Locus ceruleus mediated relative paralysis, which is seen in REM sleep. See what happens, again, a common experience. You, especially early mornings when you can hear your phone ringing or the doorbell, you want to get up, but you feel as though you just can't move your arms and legs, because that is probably in REM sleep. There is a relative paralysis which is seen in REM sleep. This is locus ceruleus mediated relative paralysis which is going to be seen. So these are the differences between NREM and REM sleep. NREM and REM sleep. ठीक है? चलो, ठीक है? Okay. All right. So this is as far as your CNS, important topics as far as CNS is concerned. Okay. And we will start. I'll give you a 10-minute break. Okay. Any useful questions? Any sensible questions? Bolo? Nothing. Okay. All right. So I'll give you a 10-minute break. And after that, I will start. There is a 10-minute break here. And then after that, we will start with kidney, renal physiology. Okay? You can take, the break is for technical reasons, right? For technical reasons, nothing much. Don't worry, break is for, like I said, technical reasons. Okay? Okay.